Good afternoon. It's once again a great pleasure to be here in Egypt. It wasn't easy to reach. Some of you might know that there was an alert yesterday at Rome Airport, and in the best Italian way, the Rome Airport was the best chaos that I've ever seen in my life. And I do hold an Italian passport, so I allow myself to criticize the country. Here we have a fantastic meeting, and it's really great to be back again. And I was asked to introduce the topic of hormone resistance that we have addressed already several times. And I will be commenting not only on the approved approach today, but also on some possibilities in the future. Let me first start by something that will be discussed later by Joseph Gligorov, which is the ABC2 Second Consensus Conference. Just to remind that this conference minutes, which are an article in Annals of Oncology in the Breast, are freely downloadable to all of you, and I believe contain very important information that Joseph will be sharing in a very few minutes with you. Obviously, we discussed in the setting of endocrine responsive disease the fact that endocrine therapy is the key treatment for these women. And we always have this debate, and we had it last year, about the presence of visceral disease when it is life-threatening. And even there, as you know, I am not certain that we have evidence that adequate endocrine therapy is not just as good as any type of chemotherapy for luminal A disease at least. The question that I was asked to address now is resistance to endocrine treatment. As you know, there have been many different definitions that have been used, and finally at the ABC2 consensus meeting, we came up with the following suggestion. If you look at the bottom of the slide, you will immediately realize that not everyone agrees. It's only 2/3 of the panel members that voted in favor of these two definitions. These definitions have evolved in the past few years, have been accepted by some North American entities as very well described in the manuscript, and we use them, at least in order to be able to have the same type of definition, study per study, in order to be able to evaluate the results of the studies with a similar patient population. This does not mean that this is a good definition. This is a working definition, and we certainly need to go for something much better. And the something much better, as you know, is going to come from next-generation sequencing. What do we do once the patients have received the standard approaches? Tamoxifen, aromatase inhibitors is an open question. We certainly can go to tamoxifen in those women that have not received tamoxifen or received in the adjuvant setting a long, long time ago. We can switch types of aromatase inhibitors, and we have been doing that for a very long time. And we now have data with high-dose fulvestrant for these women. We had old data that we should never forget about megestrol acetate, and we do now have the option of everolimus and an aromatase inhibitor. So just to give you a couple of hints about where we stand in the understanding of the field, not trying here to demonstrate anything very sophisticated, as I'm a very simple-minded clinician. I would like to remind you what is the mechanism of action that we are working on. We are looking at the estrogen pathway. And certainly we are looking at the receptor, and we're looking at the receptor degradation, and this is one of the ways of acting of fulvestrant. We are looking at the blockade of estradiol production, and this is the way that we use the aromatase inhibitors. We are also looking at the blockade of the receptor and modifications of the receptor that we understand more and more with tamoxifen. And then we are looking at what happens inside the cell. And all of these different pathways can become resistant for one reason or another. There seems that this slide, for some reason, is not projecting correctly from the computer. I'm very sorry about that. I did check this earlier. It was projecting correctly. Basically, what I wanted to say here is that we know that at the receptor level, there can be modifications of the receptor which make the receptor resistant. There can be modifications of the signal coming from the estrogen receptor. There can be modifications about the receptor itself and its polymerization. These are aspects that we know about, but for which we do not really have an active treatment. And what we are really looking at nowadays is a downstream signaling through different pathways. And what we know is that, for example, the pathway which has now received regulatory approval, where we look at the mTOR pathway and potentially PI3K pathway, is a pathway which does interact between the estrogen receptor and the pathway itself. And this is something that we need to consider when we try to understand what we are doing. This is a simplified cartoon that tells you exactly what I was telling you, that we are looking at different potential pathways. This is simplified, and we can take the next 7 minutes that are left for me to discuss it. But this is another not simplified pathway. Actually, for those of you in the front, you might read this. In the back, you won't read it. This is actually the map of the Tokyo subway. But this is the reality in the cells. It is just as complex. And we have to block different crossings in order to finally block these pathways. And this is something that we are starting to understand more and more. A single blockade is not going to be the answer of the future. The problem we have is to identify which are the driving pathways in a particular tumor. And we have failed to do this. And as you well know, in the studies that led to registration of everolimus, there was a major effort done. Unfortunately, the effort seems to have been done in the wrong tissue, because it was done in the primary tissue and not in the metastatic tissue. In spite of all of this, today, guidelines both in the United States, like NCCN, and the European guidelines recognize that we do have new answers available, and one of them is everolimus and exemestane. So how are we overcoming this resistance? Remind you about the inclusion criteria for Bolero-2, and very clearly NCCN, which I happen not to like very much, but this time I like their wording. NCCN indicates that we should put patients on this combination if they are within the realm. Trying to go back, yes. If we are within the realm of the inclusion criteria of Bolero-2, we should not attempt to treat patients that are not within these inclusion criteria with this relatively expensive and certainly somewhat toxic combination. We're trying to position this, and the role of Joseph Gligorov is going to be, among others, to discuss how do we position, what is the decision-making process that we should have in order to decide how to go from one endocrine treatment to the next endocrine treatment. Our colleagues in Germany have made this very nice suggestion, which comes from their reading of the evidence in the literature. Looking at patients who have had prior adjuvant aromatase inhibitors or have had prior adjuvant tamoxifen, and what are the choices? Today, the choice after tamoxifen is to go to an aromatase inhibitor, and only after that to consider the possibility of using either fulvestrant or exemestane or everolimus, where this is a much shorter situation according to the guidelines of the German colleagues when patients have received adjuvant aromatase inhibitors. Just a couple of words about this particular combination, which have possibly not been widely discussed with you until now. The first point is that I continue to hear colleagues of mine saying that they believe that the data of Bolero-2 is in heavily pretreated patients. No. There was a certain number of patients that were treated in first-line metastatic setting, having progressed through an adjuvant situation, and these patients did show a benefit, absolutely clear, as you can see on this particular slide. Then Also, many of us are always concerned that if patients have visceral metastasis, they might not be benefiting. But this is true for fulvestrant, this is true for everolimus and exemestane. They do benefit. The question is, which are the ones which have no time to wait until the benefit appears? However, what has also been very nicely shown in an analysis that was presented by Skip Burris is that yes, we do have responses. We do have responses, and this is what this cascade plots show to you. Responses do exist for the majority of the patients, and some of them have complete responses with this type of approach. So she would not be thinking all the time that endocrine treatment is only there to slow down the disease. We can obtain complete responses. The data from Bolero-2 allowed registration. Now we have very interesting data that has been presented both at ASCO and in the ESMO meeting recently in Madrid from our German colleagues with the study called BRAVO, B-R-A-W-O. So this study shows again the same type of progression-free survival of the patient with everolimus and exemestane as in Bolero-2, comforting the fact that these are not only study patients. For patients that are taken into account in a variety of German clinics, they are able to reproduce the very interesting benefit observed in Bolero-2 for the patients. Undoubtedly, there is toxicity with this combination. And one of the mistakes of the producing company has been to play this as an endocrine treatment just by itself. It is not an endocrine treatment by itself. It is a modulated endocrine treatment looking at modulation through the mTOR pathway. And this leads to toxicities. But we can manage these toxicities. If we are able to manage toxicities from chemotherapy, we can manage these toxicities also quite nicely. I will not go into the detail. You are fully aware of these toxicities. I would just like to make a little bit of advertisement for a paper that I happen to be the first author of and to which many of my distinguished colleagues contributed a lot. And this is easily downloadable from Annals of Oncology website. If you are not an ESMO member, you can nevertheless access it. What is going to happen very soon? Many of us have been outrageously excited by the CDK4/6 pathway, which is depicted on this cartoon. And why so? Because of a study called Paloma-1, a study for which we saw 2 years ago the first data in San Antonio. This is not a registration study. The registration study, randomized phase 3-1, is going to be soon presented to registration authorities. But this study showed on the left-hand side of the slide very exciting data, as you can see, in San Antonio. And everyone said, aha, I have to get palbociclib for my patients. However, pay attention to the part 2 of the study. Part 2 of the study is less exciting. Nevertheless, very positive results. With the drug, which seems to be relatively easy to manipulate, however leading to neutropenia, which is something that we are very familiar with and we know how to deal with. There are other agents directed against the CDK4/6 pathway, and one of these is the agent called Li-011. This is undergoing heavy investigation. Mona Lisa 2 and Mona Lisa 7 studies, which are depicted on the slide, are ongoing. I happen to be a member of the data monitoring committee of these studies. I can tell you that the first signals are absolutely what is expected from these studies. There's nothing special, and the studies are ongoing. We had some excitement initially with one study with dasatinib, which looks at the SRC pathway. Unfortunately, other studies have not confirmed those data. So for the time being, no one really knows what to do with dasatinib for which patients. So we need further data for that compound. We have many other compounds under development, and I will not have time to deal with all of these with you. And certainly other colleagues in other sessions will be mentioning some of them. And maybe next year we can develop something about these studies because they will be much more advanced than they are nowadays. But just to tell you that we have a lot to do, And it is thanks to you as investigators and thanks to your patients that we'll be able to develop these new agents in the endocrine-resistant situation. One study that is very interesting is the study with the compound called bupelisib, BEL-2 and BEL-3. These are quite advanced studies, and we do hope to have some results in the near future. So to conclude, we should stick to guideline recommendations. The ESMO guidelines in this setting, just reminding you, is that in patients that have an endocrine responsive disease, we should continue with an endocrine manipulation unless they have symptomatic visceral metastases that are life-threatening. Thank you very much for your attention.
Thank you, Professor Abro, for this elegant presentation to such evolving and highly complicated topic, which is hormone resistance. The floor is open for 1 or 2 questions, as we are still on time. Any question to the previous speaker? Oh, yes, Professor Nasr.
Whether it's a new adjuvant setting or in the advanced AI-resistant setting, in addition to the fulvestrant metastatic setting, and in the adjuvant.
Yes, and as I mentioned, it is a very exciting agent. It's less exciting as it was initially, but it's certainly going to be registered from everything we have as data, and indeed we do have also neoadjuvant data with these agents. What is very interesting in neoadjuvant studies that are conducted with endocrine agents is that, as you well know, endocrine manipulation and endocrine responsive disease is a long-term question. But we do have more and more exciting data that tells us that just looking at the drop of Ki-67 in these patients, this was very nicely shown by the lecture of Mitch Dowsett in San Antonio just a few weeks ago, is highly predictive when it is a dramatic drop to less than 1% of a very long-term benefit for these patients. This is something that we might want to think about in the near future. Thank you very much.
Okay. We received instruction from the organizing committee that we have half an hour delay, so we will postpone the discussion. The next speaker will be Professor Joseph Glikorov from France. The topic will be on postmenopausal sequence of endocrine therapy. What is the best?